Niraj, I always give you the toughest questions, so I'm going to come back to you here. I want you, think about this one carefully, but, what are your criteria on, off a study? What are your criteria for switching somebody from frontline to second line? What constitutes real world progression to you? And does that type of progression affect what you do in the second line space? I'm gonna follow up on that second point, but right now, just how do you call a patient a progressor in that frontline setting?
So obviously, this is not like what we do on clinical trials.
Right.
That's a straightforward one-line answer to begin with. I never take patient off treatment because one target lesion has grown up by 30% or 20%, while other lesions or other non-target lesions are stable or mostly or may have mildly increased in size. So I think the most important criteria for me in my clinic to take a patient off study is the clinical progression in addition to imaging progression. It's never imaging progression alone, unless there's a very high volume disease progression or rapid disease progression, which I'm going to come to later, half of this, answering your second question. So yes, patients are doing well. In fact, today I saw a patient doing well, 30% increase in the size of the main lung lesion, but other lesions are doing pretty well. He's tolerating the patient, treatment very well, planning on vacation next month. I don't want to rock the boat. We decided to repeat the scans in 3 months from now. Now, when patient comes to me, so in this case, I decided to continue the patient on the same treatment despite objective disease progression, but obvious ongoing clinical benefit. Patient is going to come back to me after 3 months. And then at that point of time, if patient continues to have slowly progressive disease, I may continue the patient on the same regimen if clinical benefit is still happening. Now, if there may be other situation when patient may show a rapid disease progression with multiple new lesions, and this patient, by the way, is on EP-Nivo combination, I will use cabozantinib or cabozantinib as second-line treatment, or maybe lenvatinib everolimus. If, hypothetically speaking, patient was on cabozantinib with nivolumab combination, if patient was being treated on that combination trial, and a patient is having disease progression, a rapid disease progression, I'll start lenvatinib everolimus. A third situation is a patient who is on a VEGF TKI, such as, say, sunitinib. I still have patients on sunitinib, and they have mild disease progression. I see that I have already noticed that disease to have progressed over last 2 or 3 scans, and patient really wants to continue to be on oral pill. I think VEGF TKI still has a part to play. I will start patient on cabozantinib in second line. So I think it's so nuanced in real life compared to clinical trials.
It really is. It really is. And those are really good, I think, illustrative, examples of how you choose one strategy or another. Monty, any thoughts on those, or any other examples where, that a certain type of disease progression leads to a certain type of management, call it second line or just a modification of frontline?
Yeah, no, I mean, I think Niraj summarized it so beautifully. I have very little to add to that. I struggle with, for instance, CNS progression. I mean, those are certainly, challenging episodes. I think oligo progression is another where, as it was sort of alluded to earlier, I try to incorporate radiotherapy or surgery where relevant. I think he gave a great all-encompassing answer.
Yeah. Well, what about this other scenario? And that is where it's not really disease progression, but it's sort of maybe chronic intolerance. So we talked about the patients that have these severe, immune-related AEs. But what about good old-fashioned just chronic fatigue, good old-fashioned weight loss from whether it's the drug or the diarrhea or what have you? Just patients kind of dwindling down, maybe lowering dose of drug down as they get a little bit weaker. And then, maybe there's some slight progression, as Niraj said, each scan a little bit worse, but not anything dramatic. How do you manage that? Do do you, in those scenarios, is that considered, do you consider that now, okay, it's time for a treatment break? Is it a second line treatment? Do you switch class of therapy? How do you manage those patients, Raina? What do you think about in terms of your toxicity management around time for a treatment change? So not necessarily clear progression, but more toxicity driven.
Yeah, I mean, I think it's I try to maintain a strategy where I can keep the patient on the therapy as long as possible. So if that means a lower dose, or maybe like lower dose that with a modified dosing schedule within the week to help them stay on therapy longer, I think that's the strategy to maintain, as opposed to like, that persistent grade 2 tox, you're right, can be pretty life altering for patients. And so especially with the TKI regimens, it may be that every 2 to 3 weeks you get a weekend off, you get 2 days off, and that's enough to just reset the clock. And patients will know they're on especially those that have been on the TKI for a long time. Or maybe somebody's having, progression, but they were dose reduced already. It's not a lot of progression, but they were dose reduced for toxicity, but you're really not, going to challenge them back to the next dose level. Well, maybe you'll do alternating days. I know that's not necessarily in the guidelines, but that's the clinical application. For example, like cabozantinib, like you may have had somebody that you dose reduced down to 20 because of toxicity. They're doing great on the 20, but maybe they've got a little bit of progression. It's not enough to say you want to switch gears altogether. Okay, I'm not going to take you back up to the 40, but 3 days a week do 40 and the remaining days do 20. Like, we'll get creative, because what I want to do is I want to milk every ounce of goodness out of that therapy that you're on, because it's not like we have an infinite number of options that we have at our disposal. So really trying to like maximize, but also being cognizant to not lose a window of opportunity where you may not be able to get them on the next line. And I think sites of disease matter. Like, I've had patients with, pancreatic metastases that kind of chug along and they're changing over time, but no other disease elsewhere. And we know that pancreatic mets kind of behave very differently than maybe other metastatic sites, or maybe they're having some lung progression. And those patients, I think, are biologically different. So I think being creative to kind of maintain, limit toxicity and maintain efficacy is key.
I think these are great points. I take the same philosophy, and I will say, and I think very similar to what Niraj said, I try to keep that frontline therapy going as long as possible, even through those kind of slow progressing signs and things. And like you said, Raina, I think that to me the reason is because every time we make a treatment change, there's a risk. There's a risk we're taking a break from therapy to make that treatment change. There could be a flare. There could be trouble getting on that next regimen, insurance issues or other issues. And there could be a tolerance issue with the second regimen that's worse than the first. So, and yet it's tempting. I mean, I know you said that we don't have that many treatment options, but last time I looked, I think there was like 11 drugs approved for renal cell carcinoma. So I've seen people, have gone through, and we're going to talk about this next, multiple lines of therapy, 5, 6, 7 lines of therapy. To me, the goal is not to use every single drug in the book, right? And now that's different than prostate cancer, where I'd like to use every single drug in the book. Here, in kidney cancer, I like to maximize, each treatment line as long as I can, without being kind of pig-headed or stubborn about it, and use these kind of creative techniques. Because I think when we modify dose, either modify dose or we interrupt dose, and I like interruptions more than modifications, by the way, but when we interrupt doses like that in order to make the drug more tolerable for patients, I think we're not necessarily compromising the biologic effect. When we start at a lower dose, when we just start a drug at half its dose, we may be undermining the effectiveness of that drug. But when we start at the full or near the full dose, and then we modify based on tolerance, then I feel like because that's drug-driven side effects, that we're still getting an adequate dose in patients. And no, I don't check pharmacokinetics on every patient, but that's sort of my poor man's pharmacokinetic. Is it a drug-related side effect? And if it is, I don't mind making modifications around it. So yeah, I like both of those strategies, and you know, Monty gets a pass because he agrees as well. So I mean, I think that, you know, we're all saying the same thing on this.